Okay, thank you very much, Mr. Moderator and Andrew. It's really a delight for me to present such kinds of delightful topic into Radiology Without Borders, as well as in Radiopedia collaborate. So we are going to start with defining the topic. So can I continue, Mr. Moderator?
Yes, we can hear you loud and clear.
Great. So when we come to Doppler ultrasound have different types of application in our body. There are different types of imaging modality. That Doppler ultrasound is one of the imaging modality which would be used in different parts of the body. But now we are going to talk about its role, its advantage in investigating different pathologies and abnormalities in obstetrics imaging. So for today, we do have a very clear objectives. So at the end of this webinar, participants, I expect the participants to understand the fundamentals of Doppler. I'm sorry if there is any is on, please switch it off for easily communication. Okay. Our second objective is to master the optimizations of Doppler ultrasound. Doppler ultrasound, unlike grayscale ultrasound, it needs a great deal of science and physics and techniques. The way how do we optimize the Doppler ultrasound will result in either we get a quality image or quality interpretations at the end of our investigation. Okay. So the third is comprehend vascular resistance and associated waveform. My fourth objective is to learn approaches for Doppler investigations of the common vessels, which will be utilized in obstetrics images like umbilical artery, uterine artery, ductus venosus, and MSA, middle cerebral. So at the last of my lecture, we are going to discuss about the clinical significance of Doppler ultrasound in different uterine pathology. So let's continue. Before we dive into talking about the hemodynamics and specific pathology, first of all, I want to highlight you the fundamentals of Doppler ultrasound. So Doppler ultrasound, it's used a change in frequency and amplitude in moving objects. Unlike a grayscale ultrasound, Doppler ultrasound used a change in frequency of what? The moving object. When an object moves from point A to point B, there would be a change in frequency when the ultrasound system or the probe receive the transmitted wave, there would be a change in that frequency. And there would not only about frequency, there will be also a change in amplitude. So those changes will be registered on ultrasound machines, and we can see those waveforms change or frequency change in terms of color Doppler or spectral Doppler. So this shift can generate a shift in backscatter signals, as I told you before. So you should understand that the frequency shift is directly proportional to the velocity of the moving object. If some blood or some fluid structure pass into the pipe, if it is high velocity or if it has a high velocity or if it has a low velocity, so the frequency shift will not be the same. So it will be different into high or to low. So as a common rule, you should also know that the frequency shift is increased in systolic waveform because systolic waveform is derived from the pumping or the pumping structure of the heart, while the diastolic is created due to the resistance due to some factors that encountered when the blood passes into the pipe or through the blood vessel. Okay, so the frequency shift is not that much in diastolic when you compare to that with systolic. So we do have two types of frequency shift. We call that positive frequency shift and negative frequency shift. As you can see from here, when the transducer is transmitted a wave, so if the direction of the blood flow is away from the transducer, so the frequency, there will be a negative frequency shift. But if there is a flow towards the transducer, there will be a positive Doppler shift. What does it mean? The received wave is greater than the transmitted frequency interval. So if there is a positive Doppler shift, the flow will be above the baseline. But if there is a negative Doppler shift, which is away from the transducer, the flow will be on below the baseline. There are some controllers which invert the thing that we saw on our spectral window or in the color window. But commonly, if there is a negative shift, there will be a flow below the baseline, and if there is a positive shift, it will be above the baseline. The great deal of thing is in the negative shift, transmitted is always greater than the received. So when we talk to fundamentals of Doppler ultrasound, there are three different types of Doppler modalities. So you should remember that there are color Dopplers, Hall Doppler, and Spectral Doppler modalities. What are the difference between the three things? We'll discuss about that. So in color Doppler, it's basically the color mapping of the flow. It's directional, and those directional flow can be acronymed by PART, P-A-R-T, which means blue is away and red is toward the transducer. And the velocity range will be also indicated in our color mapping system. So those are the velocity indications. The laminal flow will be as high as the velocity mapping than the flow which is close to the wall. So it indicates the directionality. So this is all about color Doppler. The difference between color Doppler and power Doppler is power Doppler only picks a shift in amplitude. It doesn't show us the direction. So it's basically the presence and absence of the flow. So, but unlike color Doppler and spectral Doppler, the power Doppler have its own advantage. So it's high sensitive for low velocity, and it doesn't detect any directional or number. So actually, in recent days, there are the latest machines which included directional power Dopplers, but it's out of the scope of this lecture, and we are going to say that power Doppler is only a shift in amplitude. It's best for slow flowing vessels, but it doesn't detect color flow. The other thing is spectral tracing. What the spectral tracing does is the information that we get in the power Doppler and in the color Doppler will be traced by a cosine and sine function. A cosine function is like x-axis is the flow velocity, and y-axis, x-axis is the time it takes for the flow, and y-axis is the flow velocity. So it's a real-time mappings of what would look like when we map on either the color or spectral, either on the color or in the power Doppler. So how do you optimize the color Doppler? We're going to talk about optimization of the power Doppler in the next slides, but when we come to the color Doppler, the first optimizing technique is color gain. In our machine, there is a knob which called gain, and it works both for the grayscale ultrasound and for Doppler ultrasound. When you click the Doppler ultrasound button and when you rotate the gain, that would count as a color gain in the most of machines. So it is basically amplification of the shift of signals. It doesn't increase the volume. It doesn't, it doesn't increase the velocity. It doesn't increase or decrease the scale, but it only amplifies the shifting signals. So when we get the color gain too high, so noise will become like this, and it's so much difficult to interpret things at a high gain level. If it is too low, then also we lose some important information because it will decrease the amount of information we get in the color flow, or it eliminates important slow flowing objects. So what we're gonna do is, according to ISO criteria, we will, when we do any types of Doppler examination, we will increase the color gains as much as this, and we will eventually try to decrease until we get such kinds of clean and well visualized mappings of the color of the vessels. So the only thing that color gain will do is just the amplification of each signal, nothing more, nothing less. But when we come to PRF, which is acronym by pulse repetitive frequency, or in some modern machine, it's labeled as a scale. It does manipulate the range of velocity. It does manipulate the range of velocity. The velocity of what? The velocity of blood moving into the blood vessels, okay? So if we set the low PRF, we will only receive signals from slow moving targets, and the high velocity moving targets will be eliminated. If there is a high PRF, it allows only a high velocity. But if there is a high moving velocity vessels, if there is a high blood flow within the vessels that has a high velocity, and if we set a PRF into low, then we encountered some artifact which is called alliancing artifact. We call it beyond its range. And there is also some form of alliancing artifact which is called Nyquist limit. Nyquist limit means it's the limits of the machine interest. It's the limit of the machine interest. So by adjusting the PRF, you can manipulate the range of velocity. For example, on this, there is alliancing due to low PRF scale. So when you encounter such kinds of alliancing effect, there is blue, there is red in a single vessel. So we can call this a mosaic pattern or alliancing. So when we encounter such kind of cases, what we're gonna do to obtain the best and clean visualize of the color Doppler, we will increase the PRF scale. By increasing the PRF scale, we will not encounter any form of alliance. The third thing is a wall filter. Wall filter is a selective rejection of low frequency signal. Selective rejection of low frequency signal. The term, as you see from the term, the wall filter comes from filtering the motion of the walls. When the blood passes through the vessels, then there will be a movement in the wall of the vessels intrinsically. So those are slow moving things. So when we do a wall filter at the low level, it will eliminate the slow moving and unwanted unnecessary signals. The best example is the wall motion. But if we set the wall filters as high, like 4 or 5, depending on the machine, this will create to eliminate the most important flow or the most important velocities. Okay, so we will see a perfect example for the disadvantages of setting a wall filters as high as possible. The disadvantages will be discussed in the next. The third thing is a pulsed wave spectral Doppler. The third thing is a pulsed wave spectral Doppler. So how do we optimize spectral Doppler? How do we optimize spectral Doppler? The first thing is adjusting the angle of the vessel. For example, to get a correct measurement of the vessels, so the vessel and the color gate, which is indicated here, must be at 0°. Cos 0 means the measured velocity is equal to the actual velocity of the vessel. But if there is some sort of distance, some sort of angle between the Doppler gates measurement, sample Doppler gate measurement, and the flow direction of the vessel, then the measured velocity is decreased from the actual velocity. If it's directly perpendicular to the direction of the flow, then cos 90 is 0, so the measured velocity would be 0, or we can't get any informations if we do the color knob at perpendicular to the flow of the vessels. So according to ESOG, the angle dependency error in velocity is if we make a 10-degree angle away from the 0-degree angle, we will encounter 2% velocity error from the actual flow. So the second thing is if we get 20% of angle difference, there would be 6% of velocity error according to recent researches from ESOG. So what do we understand from this? There is a certain types of vessels which need a perfect, almost a near perfect results of a velocity flow. For example, when you do for fetal anemia, we need a very accurate results of the peak systolic velocity. So we should be as careful as necessarily when we do such kinds of examination that requires a perfect velocity tracing, okay? Otherwise, that's not so much worry when we do ratio things, or when we do some qualitative analysis, it doesn't that much necessarily, okay? Just to get a perfect maximum velocity envelope and to get a perfect spectral tracing, we can adjust the gain. So as low as adjusting the angle as low as 0° is perfect thing to do. So you can see here the vessel is in this direction, which is toward the transducer. So if the vessel is toward the transducer, step up the baseline, as I indicated from the previous lecture. It acronym like BART, blue away and red is toward. And when it comes to the B, it loses its directionality. So what we say here, if it is between 0° and 90°, the measured velocity is began to decrease. You see there is a high velocity when compared to this, and it's began to decrease. And in C, it is even decreased. Then in D, there is a reverse in directionality. The flow within the vessel gets in a different direction, which is away from the transducer. That's why we get a flow signal which is below the baseline, or it's a negative frequency shift. So the other thing is a Doppler gate. Sorry. A Doppler gate is a sampled area of flow. As you can see here, this is a Doppler gate, this is a Doppler window. So the aim of a Doppler gate, placing a Doppler gate, is to record the maximum velocity during the entire. So as a rule of thumb, we must be placing those Doppler gates within the intraluminal or the center of the lumens. If we get those gates closer to the wall, we encounter the artifacts. We can't map the exact flow of the vessel. So what we're gonna do is we will use a large Doppler gate at first. Then by altering the knob of our machine, we will decrease the knob, and the Doppler gate will eventually decrease. So as long as we get perfect spectral tracing, we will decrease that vessels get a perfect velocity, inaccurate velocity, inaccurate maximum velocity develop inaccurate historic velocity result. Okay. So wider Doppler gate will result in contamination. To remedy this problem, we will reduce the Doppler gates as small as possible. So from this, you can see that the Doppler gate is placed in the umbilical vein and in the umbilical artery. That's why you get the two different types of waveform. This is the umbilical artery waveform, and this is the continuous monophasic umbilical vein waveform. So it aims to record as this is already discussed. Wall filter. This is the best thing. Talk about the physics of wall filter. According to recent guideline of the ESOG, wall filter should be as low as possible, which is less than 15 up to 16 Hz, because a lot of obstetrics vessels, fetal-maternal vessels, are displayed in the greater than those frequency shifts. Then it's really recommended to place the wall filter less than 50%, less than 50 up to 60 Hz, to eliminate, try to not to lose any important findings. So what the wall filter do in Doppler tracing, it eliminates the low frequency noise from peripheral blood vessels. As you can see here, there is a well-adjusted wall filter here. Then the wall filter is as high in this, so you lose information in the diastolic flow, or in the diastolic low diastolic pattern, you will lose information because you place the wall filter as high as 180 Hz. This results in misinterpretation because absence of diastolic flow will be interpreted as pathology, and we are going to see that pathology in the next slide. So let's see what spectral gain will do. Here is the high grainy waveform, and it follows with the less grainy waveform. So this is a high gain, and the below is a low gain. The clinical advantage of spectral gain is when you want to record a peak systolic velocity, which is closer than this, you should first increase the spectral gain as speckless, then you should decrease until you get the maximum peak systolic velocity. So it will help adjusting the spectral gain, not only helps in visualization of the spectral tracing, but also it will help to map to trace either in automatic or in the manual tracings of the peak systolic velocity, and we are going to see that when the time comes. Here is a PRF scale. Adjusting the PRF scale will result in alliancing. Alliancing, you see there is a cut in upper baseline, and it comes below here because the PRF is too low. So to remedy this thing, you should increase the PRF. You can adjust the baseline to go up and down, as you can see here. And again, according to ACR and ESOG, inversion is not recommended when we report our findings. So it's all about the fundamentals of Doppler. So let's talk about the concepts of resistance in obstetrics ultrasound. What we're gonna do is everything we are going to say, everything we are going to do in fetal-maternal Doppler ultrasound is we are just describing how much resistance it encountered through its journey. This is what we're gonna do. So first, you should understand that resistance is an impedance of blood flow, and it could be physiologic, and it could also be pathologic. So arteries can change their resistance based on the physiologic needs of the body. So what I told you before is the systolic flow is altered by the pressure gradient, which is created by the pumping actions of the heart. Then there will be a sudden deceleration here. Then there will be a diastolic peaks due to the resistance it encountered when the blood flow is through its joint. So what's the difference between high resistance flow and low resistance flow? So the high resistance flow, the waveform shows a small diastolic component. If we say the vessels has a high resistance, the diastolic component will be small when compared to the systolic ones. So we call that a high resistance. And in the severe case, if the resistance is more than moderate, or in the severe case, then you would see resistance below the baseline. That's what we call reversed flow. So low resistance flow, it continues throughout the systolic and diastolic. There is no high pulsatility. There is no juggling around the peak systolic and the diastolic. It's as smooth as it's, and when compared with the high systolic flow, the diastolic component is higher when compared to the high resistance flow. So there are different indices. There are different measurements when we deal with spectral tracing. Those indexes, some are angle dependent, some are angle independent. When we start from the angle independent measurement, the resistive index, the pulsatility index, and the systolic and diastolic volume is angle independent, because if you see here, the systolic to diastolic ratio is systolic volume over diastolic, the peak systolic volume over diastolic volume. So it has no units, so it's not angle dependent. The PI also systolic minus the RI also systolic minus diastolic over systolic. The pulsatility index is systolic minus diastolic over the temporal average of the maximum velocity. So they all cancel out each other from the unit, and it doesn't, even if we measured the angles in, let's say, 60 degree or something like that, it doesn't alter the value of those indexes, both SD, RI, and PI. So interpretation of the resistive index is straightforward. It's the simplest and easy. If the resistance increase, so the RI value will close to 1, and if the resistance decrease, the RI value will close to 0. We call those vessels as a low resistance, but when you come here, we call that vessels as high. If you get, for example, an RI of 0.930, we call that is a high resistance blood flow. And if we get an example of 0.3, 0.4, we can call it as a low resistance blood flow. Okay, thank you. Pulsatility index. Now, there is a best advantage of pulsatility index when we compare those indices, these indices with RI and systolic to diastolic ratio. As you can see from here, in acid ratio and resistance index, if the diastolic flow is absent, or let's say 0, you'll get no information. And the resistance index will be 1. It doesn't mean anything. So if in the case of diastolic flow, the pulsatility index is only option to deal with, okay? In the wave, the second advantage of pulsatility using the pulsatility index is in the waveform that have a dynamic change in systolic to diastolic, which is reversal in diastolic flow and no change. So from this graph, what you can see is systolic ratio only tell you the information that is found here and here. You can't get an information what will happen here. For example, if there is any notching here, if there is any reversal, you will not identify it in those two parameters. But in pulsatility index encountered the Tmax or tissue average maximum velocity in its formula, which is an information that you can get here. Okay, so it's a temporal average of maximum velocity. So even if the diastolic flow is absent, you will get a very important things and a very important number, which can be interpreted by using a normograph, a standard normograph. Okay, so what you're gonna do is in using pulsatility index is there are different machines that use Tmax, Tmax, and tissue average velocity. Both things can be used to calculate pulsatility index, but some latest machines use TMMX, which is my favorite, and the other is time average velocity. The difference is this calculates the mean and this calculates the average velocity that we encountered when we go down from one cycle to another cycle. So the main suggestion, my main suggestion here is pulsatility index interpretation is not straightforward. You get the number of the pulsatility index of, let's say, umbilical vein, then you should compare with the standard graph. And when you compare that with the standard graph, you should always remember that those graph is made by using either this or this. If your machine is accepting TMX, you should find a normograph that has a value which was done by the similar denominator. Okay, so pulsatility index is the most important parameter when dealing with uterine artery, umbilical artery, ductus venosus, and in the line. Okay. Next. So next, here is an indication of the formula. Here there is a well-identified spectral tracings. The peak systolic velocity is indicated here. The diastolic velocity is 0. Why? Because there is no diastolic velocity here. The Tmax is here. The pulsatility index is indicated here. The RI is 1. You don't have any information. And in SCD, peak systolic and diastolic velocity, you will get also no information. It means the RI means nothing. The peak systolic velocity doesn't calculate because the denominator is 0. So what we're gonna do is the only option is PI. Okay, in such circumstance, in the absent diastolic flow, the only option that we have is PI. Did you see that this machine is used PA max or time average maximum velocity? So the main thing is when you calculate PI, you will get 2.67. Then you should compare 2.67 with standard normograph that have gestational age on an x-axis, and in the row there is the percentile. Okay. So let's get down to clinical applications of the Dopplers. So the common feto-maternal vascular structures are, the first thing is to be investigated by Doppler ultrasound is the uterine artery, the first, second is umbilical artery, the third is the middle cerebral artery, the fourth is ductus venosus. So how do you approach for feto-maternal Doppler? When you come to the technique for uterine artery, it will have two different techniques in the first trimester and the second trimester. Basically, we as a professional use this to indicate or to predict or to screening for preeclampsia. So how you measure or the techniques for identifying uterine artery or picking uterine artery is different from the first trimester to the second trimester. So usually in the first trimester, it will be done from 11th week up to certain weeks. Then the right and the left uterine artery should be sampled lateral to the cervix. First, we have to identify the very good mid-sagittal plane of the uterus, including the cervix. So when you're juggling your probe to the right or to the left, you will find the kind of vessels. So you should map that. And as Anisog recommendation, by the way, every numbering that I put on this slide is based on a recent ISOG and ACR guidelines, okay? So, sorry. So the sample gauge must be 2 centimeter because it's a smaller caliber vessels, and you should use a sample gauge which is narrow, okay, to accurately map and to eliminate artifacts or contaminations from the adjacent vessels. Recommended angle of insinuation is less than 30 degree, and the best important trick is here. There are different vessels that you encountered laterally from the cervix. So what you're gonna do is you will measure the peak systolic velocity of that vessels, and if there is less than 50 percentile, which means if there is 60 centimeter per second, below 60 centimeter per second, you are not on the correct uterine artery places, okay? So that's indicated that you are sampling from acute arteries. So you should always see the mappings of the peak systolic velocity here, and as an example here, it's above 60 centimeter per second. So adequately mapping the uterine artery, that indicates, okay? Nice. So as I told you before, measuring uterine artery Doppler in the first trimester differs from the second and the third trimester. It's actually in the second and third trimester that's not that much important, because that's in early second trimester that's really important. In third trimester and second trimester, the other use is to identify IUGR apart from preeclampsia. So in preeclampsia, as the time goes, doing a uterine artery Doppler might not be that much helpful for the patient. Okay, if you identify preeclampsia in screening preeclampsia at 12 or 13 weeks, you can place the patient in a great benefits of using a low-dose aspirin to start, okay? So in the second and third trimester, the probe placement will be longitudinally in lower lateral quadrant of the abdomen, and after that you will angle medially. Sorry. Here's the probe placement, and you will angle medially. So after you identify the iliac vessel, you put a Doppler. So uterine artery will be identified crossing the external iliac artery, okay? So this is uterine artery. This is uterine artery. So the gauge is placed 1 centimeter downstream at this level. This is umbilical. It's the iliac veins and the iliac arteries. So this is uterine artery. After you identify the uterine artery, you should angle the probe to be parallel to the uterine artery as he did here. So the Doppler gauge must be placed 1 centimeter downstream. Angle of insinuation, as I told you before, less than 30, it would be preferable if the gate is closer than 13. But as long as we want the PI value in evaluating the uterine artery, it doesn't that much important to care about the angle of insinuation. Okay. What is expected from uterine artery Doppler? The first thing is qualitatively, we look without any measurement, just by seeing the trace, we look the presence or absence and severity of the notching. So this means notching, it indicates there is a higher resistance, and this is the absence of notching. If there is notching, especially after 13 and 14 weeks, if there is such kind of flow, especially after 13 and 14 weeks, this indicates some sort of resistances. Spiral artery is not patent. Spiral artery is not, it remains convoluted. It indicates such kind of things. So indirectly, you will screen for preeclampsia. So what you're gonna do is indicate the notch and assess the severity of the notch just by looking an eye. That is qualitatively analysis of the uterine artery. But semi-qualitatively, we are going to measure the pulsatility index, and we're going to compare with the normograph. We are going to compare with the normograph. Qualitative means just looking the wave pattern objectively. Subjectively, semi-qualitative, the term semi is used because it doesn't indicate a true value of PSV or in EDV or in diastolic velocity. It's just a ratio, okay? That's why we call it semi-qualitatively. But quantitatively, the peak systolic velocity aids in visualization of the occasion. Do you remember what I told you about mapping the acute arteries and the uterine artery? If the peak systolic velocity is less than 60 centimeters per second, you are not in the correct place for uterine artery assessment. That is the importance of qualitative assessments of uterine artery, okay? So, the other thing is umbilical artery. The technique, normally, uterine umbilical artery has a low resistance circulation. So you will see such kinds of high diastolic velocity here because it's low resistance circulation. The sumblicate must be in the fixed site, and you can put it in the fetal end, free loop, or in the placental ends. But the recommended location for sampling of the umbilical vein is at the free loop. Why? Because a lot of normographs, a lot of guidelines use this approach. But there are also certain normograph which was done in fetal end and placental end assessment graph, but the graph that was done on this location. So you can choose those, but the main thing is you should be compared those things with its synonym normograph, okay? Entering pregnancy, the recommended is intra-abdominally. Why? Because entering pregnancy, especially in monochorionic, dichorionic pregnancy, you can't identify which umbilical vein is for twin A or twin B. You can't identify which is which, so the recommended is intra-abdominal. And care must be taken when you evaluate a single umbilical artery, PI or semi-qualitatively, because single umbilical artery, there is a less resistance as compared to the normal two umbilical artery vessels, because it dilates, it also rooms in the umbilical cordus. So you should compare that carefully, okay? There is no normograph for single umbilical artery, but you should, especially if there is a borderline obstruction, you should consider that there is severity here. So you should adjust the PRF and the swipe speed. Swipe speed means this has a very high, large swipe speed, but this one is the swipe speed is decreased. When you increase the swipe speed, you will get a lot of waveforms, but this one is enough, and it's encountered as 75% of the screen real estate, which is recommended by ISO. Use appropriate well filter. This is filtered severely. This spectral waveform use a high filter. So using a high filter lose information that is adjacent to the baseline. and it will lead you to make a misdiagnosis. You see the maximum velocity envelope here is, as you can see here, and this is decrease the maximum velocity envelope from the center of this waveform is decreased, as you can see, because the well filter is severe, okay? This is high. What do you expect from umbilical artery Doppler? So qualitatively, visually inspect the diastolic flows in relation to the systolic. So diastolic flow is increasing as the pregnancy advances. It becomes less resistant, okay? Semi-qualitatively, the mighty of Doppler indexes, which are PI, RI, systolic diastolic ratio, will be used and compared to a gestational related normograph. And what I used is RI for simplicity. I use PI for accurate assessments, especially when we get a borderline pathology, okay? Quantitatively, it has no or little clinical significance, or it has no or little clinical importance. For example, if you care more to get an accurate assessment of peak systolic velocity, and adjusting the angle in umbilical artery is not that much important, okay? The main thing is the ratio. When you do either in the 0 degree, in the 10 degree, those peak systolic velocity and diastolic velocity will be mapping the same. So the ratio is the most important factor that we do. That's why we can call it semi-qualitative. The middle cerebral artery is the most important one here in the actual section. So just we can map this in the axial section just below the PVT plane. So in this plane, the thymus and sphenoid bone wing must be visualized, and we are going to locate the circle of width. Doppler gets at 1/3 of proximal MCA is mapping on 1/3 of proximal MCA, close to its origin to internal carotid artery. So if we get far from this, the peak systolic velocity is decreased. So I said that qualitative assessment is not that much important when we do with umbilical artery, but in middle cerebral artery, especially when we talk about fetal anemia, you should map the peak systolic velocity as much as accurately possible, okay? So the Doppler angle should be kept closer to 0. It's the mighty of Doppler angle is a mighty to get an accurate assessment of the velocity. So no angle correlation allowed, but if you use angle correlation, there are software angle correlation means there are software in recent high advanced machines that correlates the peak systolic velocity with the angle that you used when we place the Doppler gauge or when we place the Doppler picking angle, okay? So the advantage of gain here is when you increase the gain as little greeny as this, you can see there is a little greeny, you can't miss the smallest peak systolic velocity which are found here. So decrease again, then increase as it become a grainy as possible, okay? So you have to measure the peak systolic velocity, of the MC over and over again, but you should adjust your machines and you should take care that your machine doesn't calculate its average when you get a final report, okay? So the best measurement will be taken. It's not the average measurement. The other thing, you should not apply extreme pro pressure when we do middle cerebral artery, especially for accurate assessment of peak systolic velocity. So what is expected in MSA Doppler retrogression? Qualitatively, we visually inspect the appearance of diastolic flow in relation to systolic flow as we do on the umbilical counterpart. So if the diastolic flow is increased, which means Usually it is a high resistance blood, okay? Middle artery is a high resistance blood. So if the diastolic flow is increased, it indicates that the resistance is decreased. So it indicates there is a head sparing effect. So qualitatively, we can assess that. Then we have to measure semi-qualitatively by using PI, RI, SD, and we are going to compare into gestational age-related normograph. Quantitatively, the most important thing is to measure the peak systolic velocity as accurate as possible by using different types of physics, different types of techniques, okay? Because especially for fetal anemia, the accurate peak systolic velocity is mandatory or necessary. Okay. Here is cerebral-placental ratio and umbilical-cerebral ratio. The most common is cerebral-placental ratio. What we do is we are going to divide the mid-cerebral artery PI to uterine artery PI. It is the best measurement, especially in the borderline growth restriction fetuses. So it reflects the arterial redistribution during the fetal hypoxemia, especially when we deals about brain sparing effect or asymmetric UGR. Cerebral-placental ratio is the most important. And research suggests that it correlated more closely with fetal acidemia, fetal partial pressure of oxygen than a sole uterine artery and MC indexes. For example, in my practice, uterine artery percentility index could be normal. Middle artery percentility index could be also normal or in the borderline. So the best or the only option is calculating the cerebral-placental ratio, and it will indicate the exact figure. The last vessel that we see is in dealing with the technique is the ductus venosus. Basically, the ductus venosus connects the umbilical vein, the intra-abdominal aspect of the umbilical vein, to the left portions of the inferior vena cava. It's just located below the diaphragm. So what we do is it allows the oxygenated blood to flow into the inferior vena cava by passing the fetal liver. It helps the fetus to get adequate amounts of oxygen. So by bypassing other routes like livers. Okay. So anatomically, the ductus venosus has a pipe or small caliber at the end. It helps to eject blood into directly right atrium, then through the ovary ovule to the left ventricle, the left atrium. So that pressure is created by the pipe or the small calibers in the end of ductus venosus or at the end of the isthmus. So that's why we get color alliancing when we do ductus venosus ultrasound. That's the most important color alliancing. Which is the color alliancing indicates you are in the direct places of the ductus venosus Doppler mapping. Okay. So color flow indicates the high velocity or color alliancing used to localize ductus venosus, and it's the standard sampling type. Okay. So the waveform is usually triphasics. The systolic, diastolic, and arterial waveform will be created. So this is a different ways of mapping the ductus venosus. What we can do is reducing the gates to 2 centimeter, and the correlation must be 0, and the scale must be greater than 48 centimeter per second. So when we increase the scale, it helps us to eliminate flow contamination with the adjacent vessels. There is a different portal vein, portal artery vessels are there, so it helps us to eliminate the blood contaminations, the flow contaminations from the adjacent vessels. This is the ductus venosus waveform. So if this is a systolic, this is a diastolic. So if there is absence of waveform, it indicates some sort of pathology. So what's expected from ductus venosus Doppler integration? Qualitatively, we will look for the presence, the absence, or reversal of the A wave at any gestational age. If we found reversal of A wave or absence of A wave, it indicates severe prognosis for the fetus, okay? Reversal of A wave indicates the adverse outcome at any gestational age, especially on the third trimester, okay? Especially on the third trimester. Semi-qualitatively has a little clinical significance and qualitatively has a little clinical significance. Finally, let's talk about the clinical application of Doppler ultrasound during pregnancy. So screening, in the screening phase, we will see preeclampsia, we will see aneuploidy, cardiac defects, will be screening by uterine artery and ductus venosus assessment. And this will help in diagnosis of fetal anemia by using MCA, fetal growth restriction using umbilical artery. It will help us to differentiate or to get additional information from the grayscale ultrasound by using in the pathology during TTTS and twin anemia, polycythemia sequelae, okay? So when it comes to preeclampsia, preeclampsia is a multi-systemic disease and a multifactorial origin. So it have a different cases. From those cases, we will just focusing from defective placentation and endothelial dysfunction. So normal spiral artery are convoluted. They are small in caliber, but when there is a pregnancy, they must be dilated and the convolution must be straightened. But if there is a defective placentation, it's really associated with the most cases of early and severe PE. So that means the spiral artery, they are not in convoluted, they remain convoluted, they are not patent, they decrease in diameter, which result in resistance in umbilical artery. So that's what we call defective placentation. So pathologic basis for preeclampsia prediction or screening based on the fact of defective placentation is its result in incomplete transformation of spiral artery, as I told you before, and placental villus and vascular histopathology lesion, if there is choriocarcinoma, if there is any placental association pathology, then there would be resistance in uterine artery. And that has strong scientific correlation with P or preeclampsia. And it results in increased resistance to uterine artery blood flow. So flow resistance measurement of uterine artery gives a numeric value. Numerically, after we obtain a samples of uterine artery, we have to evaluate the most important index according to different guideline is the mean uterine artery. We will map the right, we will map the left, then we'll calculate the PI. The mean PI will be used, and there is special normograph you should be see what the normograph says in the case of PE, okay? So during the first trimester, the 95 percentiles for mean PI is 2.35. If it is above, then it will indicate defective placentation. Ductus venosus waveform is highly correlated with fetal cardiac function. It indicates the severity of fetal cardiovascular pathology. So important physiological pathway for ductus venosus, as I told you before, is from ductus venosus to IVC to right atrium to foramen ovale to mitral valve. Then if there is any problem on those paths, you will see change in ductus venosus waveform. The A wave may be absent or reversed in the severe case. So unlike the umbilical artery, unlike the MCA, ductus venosus systolic and diastolic components comes from a change in arterial pressure, which is the artery of the heart, the fetal heart, okay? But specifically, when we talk about the ductus venosus, when we talk about umbilical artery or medial artery, it's just a direct clamp of the heart, okay? But in ductus venosus, all it counts is what has changed in the atrium of the heart, the fetal heart, okay? So you can see this is a normal waveform in the ductus venosus, and there is absent in a waveform, and here the diastolic, even the diastolic waveform is decreased, and the A waveform is absent, and specific pathologies are associated with this. Fetal anemia, it's abnormal or decrease in fetal RBC or hemoglobin. The case could be a reduced alveolar cell, loss of RBC, hemodynamic dysfunction. So fetus with fetal anemia will result in cardiac velocity and will increase in blood flow velocity. The increase in blood velocity is the base for detection of fetal anemia by Doppler. Okay, so if there is fetal anemia, hemoglobin will be decreased. If there is hemoglobin, there is no hemoglobin, the viscosity of the blood will be low. So when something is less viscous, the velocity will be shoot to the rise. If the velocity is shoot to rise in MCA analysis, so it indicates fetal anemia. And the risk of anemia is high if the MCA peak systolic velocity is greater than 1.5 multiple of medians, okay? So multiple of median is indicated here. For example, this is a normal graph for fetal anemia. For example, for 30-week gestational age, the median is 44.5. So we consider mild anemia if there is 1.25 multiple of median, which is 52.2. And if there is greater than 1.5, we call it severe anemia, which is here 6.8. So guideline is recommended using multiple of media graph rather than specific velocity graph, okay? The other thing that we're going to evaluate is fetal growth restriction. So in fetal growth restriction, early fetal growth restriction is particularly associated with the maternal vascular malperfusion or placental insufficiency. So we are going to evaluate the Doppler uterine artery PI, typically precede those cascades of Doppler alteration. For example, the first thing that is altered in fetal growth restriction is uterine artery Doppler PI, which would be greater than 95. Then cerebral placental ratio would be less than 55, and as it increases, the growth restriction increases or increase in severity, they will be absent in diastolic velocity, and then reversed in the line. So the fetus will encounter such kinds of progressions. Normally, the uterine artery has a low impedance circulation. It's unidirectional and demonstrates forward flow, as you can see here. So in-diastolic flow is increasing as the gestational age increasing. The in-diastolic flow will be increased because it's becoming less resistance. So if there is decrease in in-diastolic velocity, or if there is absent, such as in this waveform, or if there is a reversal in diastolic velocity, it indicates reflects increase the placenta resistance. It indicates a damage to placenta tertiary. CPR ratio as a guideline with ESO is plus here, and uterine artery greater than 55 percentile for the given gestational age will consider as a defective placentation, and umbilical artery greater than 55 percentile for a given gestational age indicates like growth restriction, and CPR below 5th percentile will indicate this as a Doppler criteria to diagnose FGR. The other is twin pregnancy, and it's the two things that we are going to deal with twin pregnancy is TTS, TAPS, and TRAPS. So in twin transfusion syndrome, the donor interrogation involves the umbilical artery. So absent or reversed in diastolic flow will be seen on the donor. And on the recipient, there will also be a volume overload. There will also be a cardiomyopathy. Then what we see on the recipient, the pulsatility or reversed A wave in ductus venosus. So not only in the ductus venosus, but also in the umbilical artery, we will see the pulsatility pattern. So here there is absence of A wave in ductus venosus in recipient twin, and in TAPS, you will measure the middle artery for both twin. So if the middle artery greater than 1.5 multiple of median in donor and less than 0.8 multiple of median in recipient, you will diagnose twin anemia polycythemia sequence, okay? Sequelae. And the change in MCA middle artery PCV greater than 1 multiple of median is strong predictor for twin anemia polycythemia sequelae, and the formula are seen here. You will see, first of all, you will measure the peak systolic velocity for twin 1, then you will decrease the peak systolic velocity, and for twin 2, then the change in multiple of median will be calculated here. Generally, change in multiple the change in middle artery peak systolic velocity greater than 0.3 multiple of median best predict the severity of twin in hemoglobin discordant pairs. Okay. So thank you very much. This is a quick review of Doppler ultrasound, the utility of Doppler ultrasound in obstetrics imaging, and you will be welcome to question any anything that need clarity. You are welcome. Thanks very, very much. Okay.